Hello, everybody from Hamburg, Germany. I will start with my talk covering a little bit of pathogenesis and basic immunology in COVID-19. And then I will talk about the very limited therapeutic modalities we currently have. And I will talk about my view of the COVID-19 disease as an immunologic disaster and give you some data from European countries, including my own, very limited data with some experience with CytoSorb in COVID-19. Can I have the first slide, please? Next. Okay, now on the left-hand side, on the right-hand side of this cartoon, you see the healthy immune response when infected cells are rapidly cleared and the virus is inactivated by neutralizing antibodies, if there are any. And by this, of course, this will cause minimal inflammation and minimal lung damage if the body is prepared for this attack. However, in COVID-19, we have a different situation. There are hardly any specific antibodies. There are no memory T cells, no memory B cells around. So that's probably one of the reasons why there is an uncontrolled inflammation in the first place with pyroptosis and very pro-inflammatory ongoings in the tissue, leading to leakage by and vascular permeability, and also to a system-wide inflammation. Next. The pathogenesis and possible immune modulations in COVID-19 are numerous, as you can see here. For example, there are a couple of compounds and agents that are targeted against one or two cytokines or mediators, like anakinra, tocilizumab, TNF blockers, etc. You see in the lower part of the slide. However, I think, as you know, sepsis and inflammation is a very complex disease involving many pathways, or not only one cytokine, one or two cytokines. So I think the rationale to influence globally the immune pathophysiology cannot be targeting one or two cytokines, but it should probably be a way of purifying the blood by, for example, plasmapheresis or cytokine adsorption. However, as we have learned earlier today, steroid use and IVIGs may have a beneficial effect. However, if you look at the pathophysiology, steroids are very much a very global approach to inflammation and reduce the innate and the adaptive immune response very drastically and very globally. Next. So let's say that we don't have the options on the slide, number 1 and number 3, like specific T cells or antibodies. We might have a drug that is interfering with the virus replication, an antiviral drug like remdesivir. However, if we look at number 4, the pro-inflammatory cytokines that are around, there is almost no imaginable therapeutic modality that addresses this globally. So I think cytokine adsorption, controlling of excessive cytokinemia, may be at the current time the method of choice. Next. I think the viral response phase we see in the early phase of the disease is clinically accompanied by, for example, the classical clinical syndromes like fever, dry cough, diarrhea, headache, as a preliminary systemic reaction to the viremia or viral disease. And in the lab, we see lymphopenia, derangement already of some coagulatory parameters. And later on in stage 2, the pulmonary phase, the typical clinical picture we can see in COVID-19, which is shortness of breath, hypoxia, and X-ray abnormalities, as well as distal organ involvement like liver enzymes elevation, etc. And later, and I think that's the most important phase, the inflammatory response phase of the host, things become quite complicated and really important with ARDS, shock, cardiac failure, and high inflammatory markers of almost all the systems we know. Next. So addressing these changes would mean adapted to the phase that in the viral response phase, of course, the control of viral replication is the method of choice. With, for example, remdesivir or other agents we still don't have very much experience with. And later on, I think it's more important to address the inflammatory response to attenuate distal organ damage. Now looking, next please. Looking at the remdesivir studies and preclinical data, it can be said that there is an effective, there is an effect of antiviral drug, like reducing the viral titers in the tissues, especially if it's given prophylactically, as you can see in the second column, but also later on at the right-hand column, later on in patients. However, next, it is important to recognize that the effectiveness of viral load reduction depends very much on the time when the drug is given. So up to 12 hours after inoculation, the initiation of, for example, remdesivir is effective. However, up to 12 days after the initiation or after the beginning of critical illness, clinical illness, there is almost no effect of remdesivir on viral load. And this, I think, makes sense with the things I said before, that in the later stages of the disease, we have a completely different picture in terms of host response that is unbalanced towards inflammation and distal organ damage. Next. As I said, next please. And the next. Next. We have to look at the phase, at the clinical phase of the patient, and I think adapt the intervention we choose. Next. So we have to think, I think we have to move from antiviral intervention that is obviously only effective in the early phase of the viral disease towards, next, anti-inflammatory approaches. For example, as it has been clinically proven with dexamethasone. Next, please. The problem is, looking from a patient's perspective, at the lower part of the slide, you see importance to patient is very important, because I don't think that a patient is very much interested in his or her virus titers, but is much more interested in improved 90-day mortality or reduced length of stay on the ICU or in the hospitals. However, these targets become very difficult to study because the effect size of the intervention is diluted over time by many other factors, depending on the center the patient is in, depending on many confounding factors. The statistical ability to prove causality from one intervention compared to the other becomes very difficult if you look at more global outcome and patient-centered outcomes like 90-day mortality or reduced length of stay. Next, please. So let's move to a little bit immunology. As you might know, there is a syndrome we call chronic critical illness, or we call PICS, persistent inflammation catabolism syndrome. And these states are these states have one thing in common. This is an exhaustion of the innate immune response. And exhaustion of the adaptive immune response, can be recognized by looking at the PD-1 expression of T cells, for example. As you see here, on the right-hand side, you see ICU patients who have a significantly higher expression of PD-1 on their lymphocytes. Next. And this is reflected by data, human data. Again, healthy people have a rather low expression of PD-1 receptors on their T cells, and ICU patients have a much higher, with sepsis, of course, have a much higher expression, meaning that the adaptive immune response looking at T cells is compromised. Next. And next, we had that before. So I think to make things very clear, the target of our approach, next please, is to cut off the peaks, the toxic edges of the cytokine response to avoid or to minimize distal organ damage during the earlier today, next please, Can showed us very nicely his approach to analyze data differently, looking at sepsis patients, septic shock patients who had been treated with CytoSorb. Next, please. Very interesting paper, I think, and he showed the effectiveness of CytoSorb in patients who compared to the non-CytoSorb group. Next, please. The patients who were treated had higher lactate levels, higher norepinephrine dose. They had no lower MAP, they had higher SOFA score, they were sicker. And even though, next please, he could show us that patients treated with CytoSorb had a significantly higher survival rate when compared to patients who were not treated with CytoSorb. These are, as he said, retrospective data. However, they had a very nice, sophisticated statistical method to analyze these data, and I think this is very convincing. Now, there are data from Spain with CytoSorb, with COVID patients. Next, please. This group by Ricard Ferrer from Barcelona in spring showed the biomarkers measured in COVID-19 patients, and they could show that patients who had been treated with CytoSorb had clearly lower levels of ferritin, D-dimers, IL-6, CRP, and also pulmonary function was improved in terms of PaO2 FiO2 ratio. These are preliminary data from Spain. There are also German data from Freiburg, and I think you will hear about this later during this symposium. Next, please. The Freiburg people had patients requiring extracorporeal membrane oxygenation, and they treated 4 versus 4 patients with CytoSorb or without CytoSorb, and they could show that the patients who were treated with absorption, cytokine absorption, even though they had higher cytokine levels, as you see here in the graph, they could be reduced, these levels, very fast and very smoothly over the first 24 hours, and this effect lasted for 3 days. So this is, again, very low number of patients, but a very promising signal, I think. Our own cohort from spring, I share the data with you now. Next, please. We had, between March and May, we had 63 patients, 45 patients survived, 18 patients died with COVID-19 on our ICU. And as you see, and as can be expected, the patients who died had much higher IL-6 levels, much higher MR-Pro-ADM, which is a marker of vascular or endothelial integrity, and also had lower lymphocytes, again, a marker of acquired adaptive immune suppression. Of course, these patients were older who died, and they were sicker as reflected by the higher SOFA score. Next. The patients, the non-survivors in red, they had lower lymphocytes, as I said, clearly higher IL-6. This is a logarithmic scale on the upper right-hand corner. They had higher ferritin levels, not only on day one, but also over the whole course of the disease, and also higher PCT levels. Next. As I said, this marker, MR-Pro-ADM, was significantly higher in the non-surviving patients, and the same was true for D-dimers. We had a period of 14 days over which we observed these patients. Now, because we wanted to start not only an observational trial, but of course an RCT, we started CytoSorb-19. Next, please. And we had the question, does the reduction of elevated cytokine levels by hemadsorption with CytoSorb have a positive effect on the disease severity of patients with COVID-19 and shock in terms of sustained hemodynamic stabilization? And this is our protocol, or part of it. We included only patients with confirmed COVID-19 infection who were in refractory shock with vasopressor therapy, who had a rather high dose of noradrenaline above 0.2 per mics per kilo per minute, and who had an IL-6 of above 500 nanograms per liter. They also had to have either CRRT or ECMO for extracorporeal treatment, and had to be above 18 and below 90 years of age. There are some exclusion criteria you can read on the slide. I don't have to read this to you. And the primary endpoint, of course, with this rather limited number of patients, could not be mortality, but was significant stabilization of hemodynamic in terms of shock reversal, which we defined as a reduction of noradrenaline requirements below 0.05 mics per kilo per minute to maintain a mean arterial pressure of above 65 for at least 24 hours. So this is our, so to say, impromptu protocol for this randomized controlled trial, which is still running. Unfortunately, we will probably complete this trial because, as many others, we are suffering from a second wave, and we will be recruiting patients again, I'm afraid, very soon. Now, next, please. There are some very, I must emphasize, very preliminary results from the first group with 5 over 5 patients, 5 treated with CytoSorb, 5 controls. And as you can see, and as we would have expected, of course, the patients who were treated in yellow, the yellow lines, had lower IL-6 levels over time, lower PCT levels, and as predicted, so to say, and as hoped, they had lower noradrenaline requirements, as you see in the lower graph. So let me conclude this. Next, please. I think that severe COVID-19 resembles septic shock in many ways. There is a significant hypercytokinemia. I am not sure if it's a real cytokine storm. Maybe it's a very well pronounced breeze, but not a real storm, because we did not observe extremely high IL-6 levels like we would have in septic shock patients. There is, however, immune exhaustion as measured by HLA-DR and lymphocyte count and PD-1. And there's also, as you know, at least in the protracted cases, distal organ damage in terms of liver damage, renal failure, etc. Until today, a diagnostic panel concerning the immune status of these patients has not been validated. I think many groups are working on this currently, and the therapeutic intervention are under investigation, like antiviral drugs, anti-inflammatory drugs, and maybe also restoration of the compromised immune response, which I think is a very promising aspect. Now we have lessons learned from bacterial sepsis, and I think they show promise for extracorporeal cytokine elimination means, for example, cytocorp and CytoSorb, and we will see if we can reduce the inflammatory load and by this alleviate distal organ damage in the future. Thank you very much.